Okay, hi guys. Welcome back to another video. Last week I took hematpath. So today I'll be taking, and that was starting. I started malignant hematopathology. We took CML last time, and today since it's histopathology's turn. So last week I had told you about grossing of a lung specimen. So in histopathology, that's how we would be moving ahead, and at the end of each chapter I'll tell you how you can approach exams like FRC path. I'll take up a few questions from there, and we'll discuss those questions at the end of each system that we cover, like after lung. Once in the entire thoracic pathology is over, I'm going to take up thoracic pathology for FRC path. Then after I did not do it with breast, I'm going to cover up breast also. This was an idea given to me by one of my seniors, so I'm going to be incorporating it in future. So that way we'll also have a case-based discussion of all the topics that we cover. Similarly, I'll try to do something with hematpath as we move ahead with malignant hematology. Okay, so I won't waste much time. Let's quickly begin. So today I'll be teaching you approach to thoracic pathology, benign lung lesions, which is part one. I've divided it into two parts. So the topic that we are covering are grossing and its important points, which I've already done. Benign lesions I'm doing. Then we'll do malignancies, then transplant pathology, and then specialized investigation. And then I'll do that question answer MCQ kind, not problem-based learning kind of a session. So in a benign case, a patient might come to the OPD with these kind of spectrum of complaints. Say a young 13-year male or a female with breathlessness and radiology showing patchy bilateral infiltrative, not infiltrative, but patchy lesions or single unilateral lesions. It can be an adult male with chest pain and breathlessness with bilateral multiple infiltrates. 15 maybe year old female with itchy skin lesions and breathlessness. Factory worker with breathlessness, chronic smoker with pneumonia-like features. So this is an entire spectrum. Sometimes if since this is benign, I'm not going into hemoptysis. In India, tuberculosis is very common. So in cases of TB, you might also get hemoptysis. You will get weight loss. With all these things, you will get fever. So a very generalized spectrum of chest pain, breathlessness, fever, maybe hemoptysis, maybe weight loss might be there, even in benign conditions. Sometimes, if that benign condition is autoimmune, there can be skin lesions. If it is a fungal infection, there might be a systemic involvement or just the lung is involved. So, it's a spectrum of presentation that the patient comes to you with. We'll cover, we should know is radiology. Then this is how you'll investigate. Chest X-ray hoga. Then you'll do the basics investigations like CBC. After CBC, if you find something there, then you'll go ahead for other investigations. If you feel that there might be a metastasis, then you'll again, look back at radiology of other places. You will, if it is fungal, you might go for serological studies, culture studies. So that depends. And in the end, it comes the histopath and cytopathology. So, pattern of acute lung injury, this is the first part, can be either a diffuse alveolar damage or an acute interstitial pneumonia. Now, I've written something in the yahan pe niche, which just means to say that anything which is acute and is showing fibrous tissue proliferation, and normally we associate fibrosis or fibrous tissue with chronicity. But what is the difference between a new acute collagen which is forming and a old lesion with fibrosis is that the collagen is loose, they are fibroblastic rich foci, and they are very uniform, and they are very, very reversible. Until and unless that acute injury is so prolonged that this injury is happening repetitively over a period of say 3 months, 6 months, that this collagen, which is a very new, very loose collagen, uh, develops into a mature collagen. And when it develops into a mature collagen, then that fibroblastic proliferation will become chronic. Okay. So the etiology can be infections, toxins, drugs, shocks, sepsis, miscellaneous. You all know about it. So the first thing that we come across is diffused alveolar damage. Now, the changes in lung, even in acute infection, is divided into phases. Like you look at the biopsy in the first few days, what will happen. Then as it progresses, the disease progresses, then what will happen, and it will become extremely chronic, then what happens. So in that, in the first week, this is the exudative phase, मतलब secretions are coming out, ठीक है. The lining all these cells are very very reactive and secretory, so you will get sloughed material in the alveoli, you will get fibrinous exudates everywhere, and then there will be a hyaline membrane around the alveoli. Supposing this is your alveoli, then there will be a pinkish membrane. I'll show you, I have the images, lining the alveoli. So this is the first phase, and all this is due to the exudation of inflammatory material. Cytokines are there which are causing a lot of secretions to be produced. Second week is hyperplastic, where after all this has happened, now there is regeneration of the pneumocystes, especially the type 2 pneumocystes, which are responsible for the secretion, even somewhere type 1 pneumocystes, and they regenerate and start, repairing themselves. If the injury is long term and irreversible, as I told you before, then fibrosis might set in. Okay. There's something called temporal uniformity and homogeneous changes. You'll see this a lot in benign lung lesions. It means that from the pleura to the center to the, the entire parenchyma of the lung has uniform changes throughout. Okay. It is in a particular way that first, like, the vessels go, the interstitium goes, then the alveoli goes, and this change is uniform throughout. It is not patchy कि कहीं normal है कहीं uniform है. So that is temporal uniformity and homogeneous changes. Coming to acute interstitial pneumonia, mostly the cause is not definable. Some say it is viral, some say it is drugs, but it is not a definable cause. It mimics interstitial lung disease, and a very very acute form of this is known as Hamann-Rich syndrome. This is quite morbid, and it has a great mortality, with patients dying quite frequently. Like within 2 months, the patient might die if the AIP cannot be treated. Okay. So here I have a picture of that. See, there's a lot of inflammation in the interstitium. There's a lot of congestion of these vessels, and then this is an alveoli. See, the lining is even not very well maintained, and then you see this thickened material forming a coating. This is that lining that I was talking about in a DAD. Over here, it is more evident. You see this lining over here, and you see how the spaces are enlarged. There's RBCs over here. The interstitium also has inflammation. There are some congested vessels. If you compare this image with this image, there's more secretion and more interstitial thickening as compared to in this image. So maybe this is a later form of this. And then this is the final stage where you get a lot of collagen, inflammation, vessels, so now this is a later stage of something which had set in earlier. Okay. Then other acute lung injuries के diagnosis में comes BOOP or cryptogenic pneumonia, which is better diagnosed in wedge biopsies than just simple, you take punch or core punch biopsies out. It's better to do a wedge biopsy. Causes can be, it can be idiopathic, CVD, toxins can be there, infections, immune pneumonitis. What is affected in COP or BOOP is terminal bronchiolo-obliterative pneumonia or cryptogenic pneumonia. Is the terminal airways, ठीक है, जो last वाले, the trachea, then bronchi, then bronchioles, then the bronchioles is divided into terminal, then respiratory. So the terminal bronchioles are affected, and in the lining of the bronchioles you might get fibrous bodies which are known as Mason bodies. You'll get macrophages. If this Mason body is very pathognomonic of cough, you'll get macrophages. Again, there will be temporal uniformity, as all terminal bronchioles will show fibrosis. Okay. But this is it is temporal, that all of them are showing, but it is a non-homogeneous. But the fibrosis might not appear the way it is appearing in one terminal bronchiole. It might not be appearing similar in the second. But mostly it is a temporal, that all terminal will be affected. Okay. It's not that kahi respiratory affected ho jayega. Transbronchial biopsy, only diagnosis for organizing pneumonia can be given. Okay. If you don't take a wedge biopsy. Because what the picture showed you abhi just before, where the B image which had progressed, that kind of fibrosing look is of an organizing pneumonia, that now the pneumonia is organizing into fibrosis areas, into intact areas. So that kind of a look will come in transbronchial biopsy. So you need a wedge biopsy to see whether it is temporal and non-homogeneous or not. So I made this little chart out. So all these are idiopathic interstitial pneumonias or restrictive type. Now whoop was an obliterative type. This is restrictive, means they won't allow the lung to expand. Obliterative type is that there's some obliteration, so the air is not passing. Restrictive is that there's some restriction to the parenchyma from outside. The airways are clear, so it is not allowing the lung to expand. Maybe the architecture has fibrosis or there's pleural effusion, something like that. So usual interstitial pneumonia, non-specific interstitial pneumonia, lymphoid interstitial pneumonia, desquamative, giant cell and smokers. You need to learn this by rote. This is important. It will be asked. So in UIP, it's a middle age to old age, can be seen in young and there's breathlessness. Again, NSIP is middle age to old age, lymphoid in any age. In children, they coexist with HIV in immunocompromised patients and indicate EVP and can be मतलब जहाँ lymphoid है या तो वो viral है या autoimmune है and बच्चों में भी हो सकता है. Desquamative and smokers. Smokers pneumonia is superimposed with emphysema. Okay, so desquamative and smokers are two different things, but occur in smokers. Okay, and then there's giant cell, that is reaction to something like a aspirate or a heavy metal or a fume. Okay, then radiology, honeycomb. This is important. Honeycombing and spatial temporal heterogeneity is seen in UIP, while NSIP is nodular with ground glass opacity and homogeneity. So NSIP जिसका नाम में ज्यादा लेटर्स हैं is homogeneous, ground glass and N से nodular. UIP जिसके नाम में कम लेटर्स has honeycombing, मधुमक्खी के छत्ते जैसा होता है रेडियोलॉजी का अपीयरेंस लंग का, and heterogeneous distribution. Changes throughout नहीं होंगे, कहीं होंगे कहीं नहीं होंगे. Lymphoid again is infiltrate, desquamative can be ground glass. Okay. Coming to gross, there's honeycombing and subpleural fibrotic areas in UIP. Again, as I said, nodularity, honeycombing might be there and nothing specific in pleura. So you have subpleural fibrotic areas again point towards UIP. And desquamative is like pneumonia, lymphoid is patchy pneumonia. Now UIP is heterogeneous, मतलब patchy areas होंगे, कहीं कहीं regeneration हो रहा होगा, old lesions होंगे, कहीं कहीं new lesions होंगे, and areas of fibrosis मिलेंगे, epithelium में reactive changes and inflammation मिलेगा जो new होगा, जो old होगा वहाँ fibrosis मिलेगा, कहीं कहीं regeneration दिखेगा. तो UIP is a very patchy honeycomby type of a thing, and subpleural area में fibrosis मिलती है. NSIP is more homogeneous. It can be a lot of cellular reaction, reactive changes, so it is cellular. If there is a lot of fibrosis, it becomes sclerotic, and both the things are appearing together, then it is mixed. Okay, occurring in central and peripheral areas. Lymphoid, you'll see a lot of lymphocytes with germinal centers and lymphoid follicles with plasma cells. Desquamative, large amount of pigment macrophages and sloughed off some alveolar pneumocytes will be seen in the alveolar air spaces with thin rim of pneumocytes lining the alveoli. There may be areas of fibrosis too. Giant cell, you'll see giant cells. Smokers, lung, you'll see some desquamative pneumonia-like features with sclerosis. Fine, so nothing very specific. Now, what is the other prognostic factors in UIP? Not very good. Patient will die within 5 years. NSIP, which is like more, what shall I say, homogeneous patient, it has a better prognosis. Lymphoid always go for 20 and 3, and to differentiate from pulmonary maltomas. Desquamative, respiratory bronchiolitis and RBILD are smoking related precursors to emphysema. So for in the late stages again जो smoking के लंग का हाल होता है, emphysematous हो जाता है, fibrosis हो सकती है, मतलब long run term is not very good. So these are a few pictures. Now you see here lymphoid aggregates, you can see over here. All right. Then this is desquamative. You see pigment in the brown pigment in the macrophages. Similar over here. This is also desquamative. Fine. Then now this could be a more homogeneous throughout. So this could be NSIP. This could be there's some subpleural areas over here. This could be UIP. So बताना बड़ा मुश्किल होता है. It is experience. You can tell हाँ this is lymphoid. You can tell this is desquamative. But between NSIP and UIP, it becomes a little difficult to differentiate. So what we have to see is in low power that जैसे यहाँ पे normal लग रहा है, यहाँ पे abnormal लग रहा है. ठीक है. Now this is a high power. This area is abnormal, and this is extremely fibrous. So this could be maybe some sort of a fibroiding, mason body kind of a formation happening. So this is an entire spectrum where you have to see कि lesion कैसे divided and then go for a diagnosis. Needs a lot of expertise. It is not as easy as I'm sounding right now. But repeated learning and repeated reading can, so like if I would be here, I see okay, this is normal, this is not. So this is more of patchy involvement. This could be UIP. This is a high pass, so I won't comment. This can be going into a later stage where there's fibrosis developing. So this is how, and then we correlate with the X-ray findings. So in the end, this is my book. Please go ahead and buy it from Ahuja Brothers website if you are interested in malignant hematology. This is just like Washington manual or जो surgical pathology का होता है, where they give everything in points. That is what I've tried to do with my book over here. On my channel on YouTube, I have given a brief introduction of the book. I've shown कि book में कैसे tables हैं, questions हैं. So if you are interested, please go ahead and read. So this is a very short 15-minute video. Next time I'll be taking other benign lesions which I've missed, and then we are going to move ahead with malignant and as we have discussed. So have a nice day and I hope you enjoy.